Welcome to the Foresight Health Roundup podcast, Foresight Health's podcast series for healthcare revolutionaries. Outcomes matter, customers count, and value rules. Hello again, everyone. This is Dave Burda, news editor at Foresight Health. It is Thursday, July 31st. We're still not going to talk about the Epstein files on today's show, but we are going to talk about the continued overprescribing of antibiotics. I bet you didn't think I was going to say that. But I did, and we're going to talk about it with Dave Johnson, founder and CEO of Foresight Health, and Julie Murchinson, partner at Transformation Capital. Hi, Dave. Hi, Julie. How you two doing this morning? Dave?
Today is our D-Day, disembarkation day. So right after the podcast recording, Terry and I and the three cats, Buster, Benny, and Beatrix, are disembarking from Chicago to Michigan. May the force be with us.
Wow. So you'll be a Michiganer starting tomorrow? Wow.
Big
Congratulations.
chapter.
Yeah.
You're going to make some money on that tax rate, aren't you?
Oh, good luck. That's great, Dave.
You know,
good for you.
The price of the rental we're in, monthly price, is significantly less than our property tax bill in Chicago. So yeah, cost of living is better.
Good for you. Congratulations. Julie, how are you?
Well, it's been an exciting week on the West Coast. We seem to have survived a massive potential tsunami. So, lots of chatter about that this week.
Yeah, I heard about that. Everybody's safe and sound. That's great. Okay, before we dig into a new report on provider antibiotic prescribing patterns, I wanted to hear your worst story about the misuse of antibiotics. Dave, have you or anyone you know taken antibiotics the wrong way?
Oh, well, when I was the soccer coach of the Cape Palmas High School team in Harper, Liberia, West Africa, my team played on a dirt pitch with lots of stones, and the players used to get banged up, scratched up all the time. And there were two options for treatment. My preferred option was hydrogen peroxide with bandages, but that stung. And for $1, the kids could get a shot of penicillin, which made it all go away. And I fought like the Dickens to not give out those $1 shots. It came right out of my sports budget, which wasn't that large. But holy cow, the kids, sometimes I just had to give it to them because they made such a fuss. So the Cape Palmas High School soccer team were significant overusers of antibiotics.
Wow, that's a fascinating story. That's really interesting. Julie, how about you? Have you or anyone you know added to our antibiotic-resistant bacteria problem?
Well, I don't think I've been a particular abuser, but I will admit that I had a prescription that I never used, and I still have it just in case someday I could self-diagnose. So I guess I am part of the problem.
I think we all have some of that in the back of the medicine cabinet. My mom was a notorious antibiotic abuser. She insisted that her doctor prescribe her an antibiotic for pretty much everything. And as soon as she started to feel better, she would stop taking them and save a third or more of the pills for later. If there was a most wanted list for antibiotic abusers, she'd be public enemy number one. So
I think so.
Yeah. Well, on the other hand, she lived to be 86, so maybe she knew what she was doing.
Know.
Right.
Come on.
Right.
Maybe that's why she lived so long.
Exactly. But I'm not sure providers know what they're doing when it comes to prescribing antibiotics, according to a new report from Trillion Health. And there's your transition. The report out this week is based on an analysis of prescription drug claims paid by insurers. Trillion researchers looked at unnecessary or low-value antibiotic prescribing by type of provider, type of care setting, and by state from 2018 through 2023. They defined unnecessary prescribing as the percentage of patient visits for upper respiratory infections that resulted in a patient being prescribed an antibiotic. Here are some of the top-line findings. The percentage of unnecessary antibiotic prescriptions rose for all three types of providers from 2018 to 2023. It rose from 11.7% to 13.7% for doctors, It rose from 14.5% to 17.1% for allied health providers like nurse practitioners and physician assistants, and it rose from 11.5% to 15% for other types of clinicians. The percentage of unnecessary antibiotic prescriptions varied across 4 types of care settings in 2023. It was the highest in urgent care at 17.4%. It was 17% after telehealth visits. It was 15.7% after in-office physician visits, and it was 6.9% after emergency room visits. And the percentage of unnecessary antibiotic prescriptions varied significantly across states. It was the lowest in Wisconsin at 7.3%, and it was the highest in Arkansas at 22.8%. When was the last time Wisconsin led the nation in anything besides NFL championships? The report called antibiotic overprescribing as, quote, a persistent public health challenge, close quote. And it said prescribing behaviors are influenced by clinical training, financial incentives, patient expectations, time constraints, and organization-specific policies and protocols. Dave, is there anything you'd add to the list? And from a policy perspective, what would you do to address these issues and get providers to prescribe antibiotics the right way?
Well, before we get to antibiotics, Dave, I think you're understating Wisconsin's impact on the nation. I'm sure they are number one in dairy production and per capita consumption of bratwurst. So you got to give them credit for that.
Okay. I'm sure you're right on both those.
Reading the report, I was struck by just how much variation there is in treatment patterns among clinicians. For all the attempts to standardize treatment protocols, it's remarkable how many clinicians still color outside the lines when it comes to overprescribing antibiotics. Overusing antibiotics is bad in 2 distinct ways. First off, they kill good bacteria, never a positive thing to do. And the second thing, probably more serious, is they build antibacterial resistance, something the CDC in 2018 said was causing an existential threat to mankind. The World Health Organization is all over this topic. As an aside, the United States was the founder of the WHO, but thanks to the Trump administration, we're relinquishing our membership. Very far-sighted policy there. But anyway, the WHO issues a couple annual reports on antibiotic usage across all countries, territories, and areas, CTAs. They look at the patterns of usage and are trying to get the right distribution of the relative strength of antibiotics for the right diseases. Long way to go, but enormous focus on their part. And they also track the number of new antibiotic drugs in the development pipeline. They're particularly worried about 2 things. One is a really uneven distribution of antibiotics between CTAs, country, territories, and areas, remember. And then the disproportionate use of more powerful and expensive antibiotics for common infections. And that, of course, creates a higher likelihood of the development of antibacterial resistance. Of the factors you listed, I'd like to double click on patient expectations. Just like my soccer players in Africa, consumers often demand antibiotics even when they don't need them. They're easy, cheap, and often effective. There's a significant level of consumer ignorance. Antibiotics don't cure a cold, even though a lot of people think they do. It is an antibiotic, not an antivirus. So it's not going to cure the flu or cold or any other viral infection. So clearly we need better consumer education. Attempts to better inform the public have largely failed. You asked what I would do. I'm feeling like a pretty good economist right now, and any economist will tell you if you want less of something, tax it. So I think we ought to start doing some pretty serious fines on this to get the attention of hospitals and clinicians. Tell them to stop it. Let me end with this. Does it surprise either of you that Arkansas had the highest level of overuse at almost 23%? That was 3 times the overuse rate of Wisconsin, Dave, which you highlighted. So go Badgers. I looked at that. It reminded me of that song from the musical Big River about Arkansas. Arkansas, Arkansas, I just love old Arkansas. Love my ma, love my pa, I just love old Arkansas. And I guess they love antibiotics too, because they take way too many of them. I mentioned Arkansas for another reason, but I'm going to keep you in suspense until we get to the last segment of the podcast.
Mystery from Arkansas. All right, Dave. Julie, any questions for Dave?
I'm always amazed by the reach of music that Dave has. It's really unparalleled in my life, honestly. Okay, Dave. So back when I was working with Julie Gerberding, who was CDC, Merck, this is a big deal. In 2015, 16, 17, CDC promoted big antibiotic stewardship program. JACO got involved with health systems. CMS issued requirements, like a bunch of states created reporting. There were HEDIS measures. Incentives and ACO models, like so much stuff. So what's changed to render all of that, just not sufficiently effective? Things have gotten worse.
Yeah, you're right. As I mentioned before, the CDC in 2018 called, what's the fancy term they use? AMR, antimicrobial resistance, that AMR posed an existential threat to mankind, to humankind. And then there were all kinds of programs, and they didn't stop in 18, 19. John Perlin, who we both think quite highly of, right, as head of JACO in 2023, issued new standards for hospitals to combat AMR, antimicrobial resistance. He gave a full-throated commitment to doing research, to providing tools, to educating hospitals. They noted that this AMR causes 3 million sicknesses in the U.S. each year, kills 35,000 people. It's not trivial, right? Not to mention the superbugs and the potential to have infections that we won't have antibiotics to treat. They even came up with a Speak Up on Antibiotics campaign, and they had a website, Antibiotic Stewardship, and I clicked on it, and unfortunately it's now defunct. Got one of those 404 error messages.
So much for existential threat.
Well, there was this great political cartoon from the 70s when Nixon had all of his economic programs, phase 1, phase 2, phase 3, and phase 4. And the political cartoon after he did phase 4 was a football coach on the sidelines with one of those down markers saying phase 4. And Nixon, the caption had Nixon saying punt, right? It feels like, Julia, the issue hasn't gotten any less urgent. But it's like everybody tried, it didn't work, and they're moving on to other things. I think we got to try harder, personally.
Okay, Julie, it is your turn. Was there anything missing on the list of antibiotic prescriber influencers? And what would you do from a market perspective to steer providers in the right direction when it comes to prescribing antibiotics?
Well, I actually thought the report missed a bunch of concepts here. First of all, like the lack of easy access to point of care, rapid diagnostics, like it's a big deal. And without that, providers just play it safe, right? I'd say the same thing about malpractice. Like, if doctors are in a hurry, want to make sure that they're covering themselves, don't want to have to deal with the hassle of malpractice or financial issues, they're just going to play it safe. So why wouldn't you prescribe? Now, here's one I think is kind of fun to think about. The report mentions time constraints, but it doesn't look at how the EHR design might make it faster to actually prescribe antibiotics than documenting some sort of wait and see plan. Like the clunky documentation and the short visit windows, we're rewarding speed. We're not rewarding kind of the nuance of the situation. Love that one. And because I grew up on this side of the house and I beat the drum all the time still, the report doesn't mention the importance of interoperability. And just like there are drug seekers in so many categories, everything's still quite disconnected and there's no full clinical picture. So patients can seek antibiotics all over the place. They're just realities I felt like they didn't discuss. Should they have? I don't know. But, for me, Dave is so right about provider education to manage patient expectations. So right, Dave. Of course, I think in the world of technology and clinical decision support goes a long way here. And it's not just like real-time alerts and evidence-based guidelines and the things you normally think about. Like, think about functionality that links like diagnosis linked prescribing logic that can flag, justification for antibiotics, or also suggest like deferred prescribing options or other alternatives. Like, clinical decision support goes a long way. And what we need to do is make sure that we're tailoring it to the setting and to the provider, because there's clearly a lot of data here that shows that those are, big drivers of variation. Dave, your comment about the variation in provider prescribing patterns, like why we don't have prescribing dashboards like front and center. Physicians are now used to being, shown how their patterns or practice patterns are different than their peers. Like, we should be doing that everywhere around this if we're really serious about it. And I was kind of intrigued by the telehealth issue. It's not surprising to me that telehealth has higher rates of pretty much low value prescribing. So maybe there need to be different ways of treating telehealth because of just the venue, right? You could actually require some sort of asynchronous review or, escalation, or use AI in the way that even radiology does to provide a data-driven way of looking at the patient who's over, video or phone with you. There are ways to kind of put safety nets in if we're concerned about that lack of human connection that would drive an antibiotic prescription. So I think there's a lot that could be done here. And then lastly, of course, we could enable more at the pharmacy level. Like, imagine, and I think this probably does happen in some places today, of course, but pharmacy level prompts before dispensing for flagged prescriptions. So there's one more like fill step. Pharmacists would love this, of course, right? To add another gate before some sort of unnecessary antibiotic reaches the patient. It's a pain, but it could help, honestly. Pharmacists know what they're doing.
Yeah, it's interesting with opioids, right? You have to override the system now if you want to go outside the prescribing recommendations. And that's helped produce over-prescribing of opioids. Why can't they just scratch that out and put in antibiotics? Well,
exactly.
They could. I guess they could, but they haven't. Thanks, Julie. Dave, any questions for Julie?
Yeah, I do. But before I get to my question, Dave, you and I were thinking along the same lines. It strikes me that part of the issue here, and Julie, you hit on it really clearly, is it's too easy to hit the easy button to prescribe the antibiotics. So let's put some steps in there, some breaks in the process. I think we should find them too. I mean, the variation is just simply too great, but put some breaks in the process. Let technology gum up the works a little bit here for the benefit of patients and broader society. Well, Julie, I want to go to the other side of this, which is the development of antibiotics. The World Health Organization, in its annual 2024 report, noted that the biotech industry isn't developing new antibiotics fast enough to combat rising antimicrobial resistance, AMR. Do you agree? And if so, what can the healthcare industry do about that? Pretty serious threat.
Yeah, I do agree. I mean, this isn't just like a research issue. It's a market failure. And the ROI on developing antibiotics is, there's no other word to put to it than weak. And especially when you compare it to oncology drugs or chronic disease, so many other drug categories. So WHO is right to sound the alarm, and we need to rebuild the economic model for antibiotic innovation. And, if we matched it with this clinical discipline we're talking about and with the policy support, we could do a lot here, but if not, we're heading into some sort of post-antibiotic era where, routine infections could once again be deadly. And honestly, between that and the vaccines, like, God help us. But it's not just about the financial incentives and kind of all the market structure things. Like, well, maybe this is part of that. But again, I go back to rapid diagnostics. Why aren't we looking at investing more there as well? Because that's part of the solution. We think so kind of singularly about these things.
Dave, your story about your stint in Africa reminds me that when I was a kid, no matter what you went to our GP, general practitioner, for, you got a shot of penicillin and a little white box of tetracycline pills. And that's it. You're on your way. It didn't matter what you went in there for. Thanks, Julie. Thanks, Dave. Great discussion. Now let's talk about other big healthcare news that happened this week. Julie, what topped your list of things we should know about?
Well, in case you missed it, the White House and CMS launched a health tech ecosystem initiative to expand use of digital health with a focus on consumers. Wow. Major. Let's see what it is. Yeah.
Okay.
Exciting.
Maybe that'll be topic for an upcoming podcast. That's
Perhaps.
Great. Yeah. Dave, what's your big story of the week?
Well, PBMs won a legal victory this week in, drumroll please, Arkansas. A judge temporarily blocked a first-in-the-nation law that would prohibit companies that own PBMs from operating retail and mail-order pharmacies. Go Arkansas. Love my ma, love my pa, love old Arkansas. Let's go get that judge's block overturned, and let's make this an example of progressive reform.
Yes, here. Well, before we sign off, I just wanted to give a shout out to Medicare and Medicaid, which both turned 60 yesterday on July 30th. So happy birthday.
Happy birthday.
Right? Hope it lives to see 120. I'm not sure. Thanks, Dave, and thanks, Julie. That is all the time we have for today. If you'd like to learn more about the topics we discussed on today's show, please visit our website at foresightshealth.com. You also can subscribe to the Roundup on Spotify, Apple Podcasts, YouTube, or wherever you listen to your favorite podcasts. Don't miss another segment of the best 20 minutes in healthcare. Thanks for listening. I'm Dave Burda for Foresight Health.